Hello students, welcome all to the session of Sparks. Here today we are going to discuss about the frequently asked questions. Mainly these are all the topics which were especially important for all the examiners and all the points of view in exam. In the last session we have seen about the antepartum hemorrhage, what happens within the age of viability and before the delivery of the fetus. If suppose the patient comes with the bleeding of complaints of bleeding, then what will be the interpretation? Now today we are going to see about the postpartum hemorrhage. This is a topic which all have been supposed to ask, and very important. At any course you'll get one question, at least one or two questions regarding in the direct way or in the indirect way as well. Now going along with that, the definition of postpartum hemorrhage is very important. What is the definition of postpartum hemorrhage? See, it is a blood loss, or you can say bleeding after the delivery of fetus. Okay, bleeding after delivery of fetus. So before in the antepartum hemorrhage, what we have seen? We have seen before the delivery of fetus, after the age of viability, right? So here in the blood loss will be bleeding after the delivery of fetus. In that too we have been divided this PPH, postpartum hemorrhage, into two. Again, that is your primary postpartum hemorrhage PPH and your secondary postpartum hemorrhage PPH, secondary postpartum hemorrhage, right? So in these two kinds of a postpartum hemorrhage, if suppose bleeding within 24 hours, that will be your primary postpartum hemorrhage. If more than 24 hours or after 24 hours of delivery will be your secondary postpartum hemorrhage. Clear? So definition leads to bleeding after the delivery of fetus. And one more definition which we can say is, here I'll be writing, blood loss more than or equal to 500 ml in NVD. What is NVD? Normal vaginal delivery of a single fetus. One more term, more than 1000 ml of blood loss in twin pregnancy. That will be your postpartum hemorrhage. Please remember the causes. 4 T's we have mentioned here. What are all the 4 T's here? One is your T, which is tissue, and the other T is your tone, trauma, and your thrombus formation. So these are all the 4 T's which are a very important question which has been asked already. Here, which is the most common cause for this 4 T of a cause of postpartum hemorrhage, and the most common cause here, tone. Most common cause of your postpartum hemorrhage is the tone of the uterus is very important. Now coming to the next point, what are all the risk factors? We have given a mnemonic here, that is A, B, C, P, R. A means the age of the mother is important. And B here belongs to a big baby. These are all the very few important clues which you have to at least concentrate on. Now coming to the CP2R. What is CP2R? C, I am making it as O. What is O? O is your over distended uterus. These risk factors are very important because these are going to give you a clue for finding the answer. So over distended uterus. And what is your P2? Two P's are there. One is your prolonged labor, and another one is your placental abnormality, right? So one more thing, R is your retained placenta. So these are all the main risk factors which you can see in your question whenever there is a clinical question asked regarding to your postpartum hemorrhage. You can find by these kind of a clue words, right? A, B, C, P2R, which is your over distended uterus, means the uterus which is failed to relax. It will be in a relaxed position, but it will be failed to contract further for the stoppage of bleeding. Now coming to the next thing, how will you manage the postpartum hemorrhage? These are the short and very important concentration of points which you have to see while you are solving the clinical questions. So in the clinical management, first you will be doing calculating the shock index. How can you calculate the shock index? See, shock index SI is normally calculated by increased heart rate by decreased systolic blood pressure. So the normal shock index is 0.5 to 0.7. If at all this shock index is dearranged, if there is a problem or a variation in this shock index, then that will lead to your difference in the bleeding position, which causes postpartum hemorrhage. You have to be focused on that, what shock index is. So in the question, they will not directly say what is shock index, what is heart rate. They'll give you a clue of the patient after the delivery will be coming with the complaint of hypotension, and her BP might be, for example, 100 by 60 or 90 by 50 sometimes. This decrease in blood pressure, which makes your cardiac output and the cardiac pumping to be more. This makes your heart rate to be increased in turn. This both vice versa terms of your heart rate and your systolic blood pressure causes this shock index to vary, and sometimes the mother might go in shock. Sometimes the mother might go in shock. That is the very important thing which you have to remember. And the first step to be done, what is the first step for this patient to be done? And IV fluids, especially RL fluid of 1500 ml should be given, and blood transfusion should be ready for sure, and her blood cross matching, everything should be in ready, as such she is in loss of blood. So one more important thing, this question has already been asked in your FMG exam, might be in 2018. Catheterization of the bladder is done for a patient with a postpartum hemorrhage after within 24 hours of bleeding. Why? Because once the catheterization of bladder is done, bladder catheterization is done, this will make the contraction of uterus to stimulate. Contraction of uterus to stimulate. Once this contraction is there, then there will be more possibilities for your myometrium to contract, which further stops the bleeding. This is why you are going to catheterize the bladder. Now, the next here, the clinical management which is shown in the picture is BUC. What is BUC? Bimanual uterine tamponade, or you can call it as compression. Compression. Bimanual uterine compression. See what they are doing? They are making two hands, one hand in the lower abdomen and the other hand in the pervaginal examination view, like the whole hand they are keeping like this, so that the uterus gets contracts. If it is failed to contract further, it makes the stoppage of bleeding. This is one of the important clinical management where you can decrease the bleeding level. So this picture question is also asked. Now, then what will you do? Even after the massage, even after the compression, your bleeding is not stopped. Still the patient is bleeding, still the mother is bleeding. Then you have to give oxytocin of 20 units IV, followed by, first your method should be oxytocin 20 units you are going to give IV. Then it is followed by methergine injection. Methergine injection, this is also given IV. If this also doesn't work, then you have to come by the follow of misoprostol. This is also a question which is asked, and the dose is very important, that is 800 micrograms, that is per rectally given. Per rectally given. First we have given IV bolus, even the bleeding is not stopped, then we are going to give a misoprostol as per rectum, and if at all the bleeding is not stopped, further we have to go for a IM of carboprost. Carboprost. Carboprost is 0.25 milligram IM should be given. So we have to try in all the ways. All the ways we have to try. So still there is atony. Atony means there is no contraction of the uterus. Then what you will do? You have given bimanual compression, you have given methergine IV, you have given oxytocin bolus, even you have given IM, and you have tried in a perirectal way. Still the bleeding is not stopped. Then what you are going to do? You are going to see whether the placenta expulsion is completely done or not. So you are going to check whether the placenta expulsion is completely done. Once this is done, we are going to try a tamponade called as a balloon tamponade. Balloon tamponade. I hope you can able to see the picture over there in the screen. See, first we have to insert this balloon tamponade. Then we have to fill around 500 ml saline in them. We have to fill 500 ml saline in them so that they will be fixed, and they try to contract the uterus, and they try to decrease the bleeding level. The next step. If you see in the next further step of management, what we have to do, first you are seeing the site where it is bleeding. So compress the bleeding site. Compress the bleeding site where it is bleeding. or else you have to insert the Bakri balloon, which we have seen now. And if at all every management fails, then you have to go with the surgical management. So what is the surgical management here? One is your suturing you can do, or you can do devascularization. What does it mean by devascularization and suturing? Suturing means just you have to tie the place where it is bleeding from, and devascularization means totally you are going to ligate the blood supply. So in suturing, what and all we can do? One is your B-linge suturing. It is in a kind of a B, and core sutures, and Lyman sutures. These are the kind of a suture we can do while there is a postpartum hemorrhage. And what are all the devascularization we can do? The first thing you can do is your bilateral uterine artery ligation, the first artery to be ligated. Bilateral uterine artery ligation. Second, here I am writing the second one. Second, you can do bilateral internal artery ligation, internal iliac artery ligation. So you can do internal iliac artery ligation. Everything is done. So after that, what you can do? Even the bleeding is not stopped further. Then what you can do? You can go with ovarian artery ligation even sometimes, because there is a chances that there will be a bleeding from your ovaries too. So bilateral ovarian artery ligation to be done. Clear? So these are the three things which you can do for the devascularization. First is your uterine artery ligation. Second is your internal iliac artery ligation. And if it is not stopped, then you can go with ovarian artery ligation. Now, this is the picture which shows the ligation of the internal iliac artery. See, this is the common iliac artery. For suppose, and this gives the branches of the external iliac artery and the internal iliac artery. In the internal iliac artery, please remember, this is the question which is asked already. Internal iliac artery have two branches, which is your anterior branch and the posterior branch. If at all you are doing ligation for the postpartum hemorrhage bleeding, you have to ligate the anterior division. Anterior division should be ligated. Question. Anterior division should be ligated. Anterior division of internal iliac artery should be ligated. That is what which is shown in this picture. You should never ligate the posterior division. The posterior division should be spared. Okay. Now, never do this. What you should not do during the clinical management of postpartum hemorrhage? You should not do uterine packing. Like how we are doing in the nasal bleeding. We do nasal packing and the nasal devascularization for nasal bleeding. Same like that in postpartum hemorrhage. Don't please think of going in uterine packing, or you can be going with the ligation, but you cannot go with uterine packing. And please remember, you can also not go with suctioning of the uterus. Just because it is bleeding, don't think for the suctioning. These two things should not be done at any cost in your postpartum hemorrhage. So never do ligation of which arteries. So we are doing ligation. So we should not do ligation of which arteries? Question. Common iliac artery should not be ligated at any cost. As such, these arteries are very important for our lower limb blood supply. So common iliac artery should not be ligated. This is a question exception, right? Now, WHO preferences for our postpartum hemorrhage is to give tranexamic acid. Okay, tranexamic acid, which should be given as first. This is our WHO preference. But the first line drug, if they ask what is the first line drug for your postpartum hemorrhage, then you have to say that it is uterotonics. So these two things are very important. Please remember what is PPH, how to manage. They can ask by the clinical symptoms, or else they can present the case by the way of how the patient feels after the delivery of fetus. So some questions are there. You can see. A patient 32-year-old had a NVD. NVD in the sense she had a normal vaginal delivery with birth weight. Please see, it is 4.1 kg. She is having bleeding even after the bimanual compression. So bimanual compression is done and massage of the uterus. So both of the things are done. Even the bleeding is not stopped. Followed by oxytocin IV bolus is given. So the oxytocin which was being given in IV is also given. But still there is bleeding which is not stopped. After even giving oxytocin, the patient is still bleeding. So what is the next step of management? Please see the option. Option A is your Buckley balloon insertion. Option B is your misoprostol 800 micrograms should be given, and ligation of the common iliac artery, or you can go with hysterectomy. As such, we have seen in the clinical management, we cannot go with Buckley balloon insertion because we have to try all the medications, right? So just till now, oxytocin is given. None other than other medications are given, and directly we cannot go to ligation of the common iliac artery, which is very wrong, which is very wrong. Common iliac artery should never be ligated at any cost. So directly you cannot go to hysterectomy. As such, the patient age is just 32 years. In the hysterectomy indications, the patient should be a postmenopausal woman, or she should be more than 42 years, right? So in this patient, you can give the next level of management, that is your misoprostol 800 milligram, which should be given per rectally. The most preferred administration of misoprostol 800 microgram is per rectum. Clear? So this is how you have to follow the question along with the concept which we have been read. So the next question, which is a very small question, just to aware of this question is asked in your FMG exam 2016 itself. This picture have been given. So what does this picture shows? This is the anterior part. It is a kind of a suture, yeah, we know. But what kind of a suture is this? This is a kind of a B-link suture, right? This is a kind of a B-link suture. See, in an anterior division, if they have been giving an image also, you are supposed to find it. And if suppose they have given in a posterior part, then also you have to find what is the suture. If you can see, it was like this. It was like this. So we are calling it as a B-shaped or a B-link suture. So one more small question, most common cause of postpartum hemorrhage, a very important question, a repeated question. Many times it was being asked. Option A, retained placenta, atony uterus, trauma, genital tract infections. What will be the answer? Obviously, your answer should be from any of the 4 T's. That one of the T's your most common, that is your atony uterus. Atony uterus. Clear? So these are all the most common things which have been asked in your postpartum hemorrhage. Apart from this, none of the questions can be asked literally. If you know, or if you're able to see the clinical signs, what they have been mentioned in the question, it will be very easy for you to answer the question. And it will be very easy for you to interpret what type of hemorrhage they have been speaking about. Either it is an antepartum hemorrhage, which we have been discussed in our last session, or it might be a PPH, postpartum hemorrhage, right? So this is all the session of postpartum hemorrhage. Please be aware of all the pics. Please be familiar with all the picture images. These are all the most commonly hot topics of examiners also. Thank you.